Now, we already seen the ST elevation MI and diagnosis investigations. In this part, we'll be looking after the treatment part. So, in the treatment part, we'll be seeing the immediate treatment that we must give and some support to treatment. Now, we must know ST elevation MI or MI is basically a blockage in the coronary artery, and this blockage is not like 50%, 60%, 70%, 80%, 90%, 95%, but in fact it is complete 100% occlusion of the artery. It can be left anterior descending artery, right coronary artery, or it can be left circumflex artery or any artery, but the blockage is complete and it is 100%. Now we must come to know that whenever there is clot formation in the artery, the most important thing is this endothelial injury, the damage which is there. There can be a plaque which can be already there, and there is an injury to the plaque, or there can be an injury to the endothelium, which causes release of thromboxane A2, endothelin, and other chemical like platelet derived factor. These chemicals, these are locally released, which attracts the platelets to these sites, and these platelets then they aggregate and they form a clump, they form a plug, and this plug keep on increasing, and it actually attracts each and every cell. So in short, you'll get so many RBCs, neutrophil, lymphocytes, everything which is attached or which is present in this clot, and there will be activation of all the clotting factors causing a formation of clot. So this clot is a heterogeneous thing where you have platelets, RBCs, WBCs, neutrophils, lymphocytes, fibrin, and so many things. So, if this clot is persistent, then definitely the myocardium, which is supplied by this artery, will get 100% damage. So, what we do treat this with main two drugs. That is, the first is antiplatelet, because the initiation of the clot formation is by platelets itself, and the second thing is whatever the clotting factors are there which are very active, which are forming the clot, we have to give anticoagulant. So to prevent the coagulation, further worsening of the coagulation, and to reverse the coagulation, we have to give anticoagulation, and to prevent the further platelet activation and further clot expansion, we have to give antiplatelets. Now we know any MI patient presenting to the hospital, to the emergency, having severe chest pain, diaphoresis, palpitation, we have to give loading dose of ecosprin 300 milligram. That can be given with either clopidogrel 300 milligram or ticagrelor 180 milligram. So we usually give 4 tablets of ecosprin, 4 tablets of clopidogrel, or 2 tablets of ticagrelor 90 milligram. So these are given in combination. Now, the usual antiplatelet dosage is 75 milligram of ecosprin, 75 milligram of clopidogrel, and usually the ticagrelor is given postplasty at the dosage of 90 milligram twice a day. But to load all the platelets which are circulating in the blood flow, or to inhibit all the platelets, we give this loading dose, so that this loading dose gets accumulated in all the platelet. That is the reason why we give loading dose. And along with that, to prevent, because whatever this plaque is, it has a very very high lipid content, and this lipid content which is broken, this lipid content which is broken because of the clot, is very highly atherogenic, means it has very much risk of formation and expansion of clot. That is the reason why we give statin in a loading dose. So statin loading dose is either rosuvastatin 40 milligram, which is high dose, or atorvastatin 80 milligram, which is twice the dose of rosuvastatin. So this is the antiplatelet and the statin which is given immediately as soon as the STEMI is diagnosed, without delay or without doing anything. The second thing which we have to give is anticoagulant. Now, almost everywhere, injection enoxaparin or Clexane is prescribed. Usually, the dosage is 0.6 uh, uh, ml twice a day, which is actually 60 milligram twice a day. If the patient's weight is usually above 50, this 60 milligram twice a day is very commonly used. If the weight is less than 50, then 40 is used twice a day. This is almost one of the most commonly and most extensively used injection available in subcutaneous form. If by any reason this enoxaparin or clexane is not available, or if the patient has CKD or the patient's creatinine is raised, then injection heparin 5000 unit can be used instead of enoxaparin, and it is given usually 6 hourly, 4 times a day. That can be given subcutaneous or IV as well. Usually it is given IV for a better efficacy. And apart from this, injection fondaparinux is also used, which comes in only once a day dosage, and it has shown to have a lesser bleeding risk. So this is one of the most important, most emergent treatment that the patient must get without any delay in any scenario. And the second part of this is supportive treatment. In supportive treatment, one of the most important thing in any patient who is presenting with ST elevation MI is to look for vitals, because if the patient survives, then only we can do the treatment. If the patient doesn't survive, we cannot do the treatment at all. So the most important thing is vitals. What in vital is heart rate, respiratory rate, BP, and saturation. So we must check the heart rate for bradycardia or tachycardia, because if the patient has inferior wall MI, if the patient has inferior wall MI, then in this the right coronary artery is involved, and this same right coronary artery supplies SA node. So if this RCA blockage is there, patient may have complete heart block, or patient may have bradycardias. So if the patient has bradycardia, patient may need isoprenaline, patient may need atropine, patient may need adrenaline. So the patient must survive for the treatment. So if the patient has bradycardia, atropine or isoprenaline or adrenaline or dobutamine or dopamine can be used to increase the heart rate to a certain level, at least around 60. And the patient may also have tachycardia. The tachycardia can be because of the myocardial damage itself. And the tachycardia can be ventricular tachycardia, SVT, ventricular fibrillation. So whenever the ventricular tachycardia is there, if it is unstable, we have to definitely give a shock. If it is stable, then injection Cardron, that is amiodarone or dilzem or diltiazem, can be used to control this ventricular tachycardias. If the patient has ventricular fibrillation, then again we have to shock. There is no choice for ventricular fibrillation, has to be always shocked. And if the patient has a systole, means the heart is not at all pumping, we don't have any choice than to give CPR until there is a revival of the normal beating cycle of the heart. The next important, most important thing is blood pressure. If this is heart attack, means the heart muscle is not pumping. The patient may present with hypotension, or patient may present with hypertension. Now, this hypertension is very common in especially anterior wall MI, where there is either LMCA blockage or LAD blockage. Now, if the patient has hypotension, then it has to be definitely corrected with either a very cautious use of IV fluids, because the patient may land up in again pulmonary edema. So maybe fluids can be started at 30 to 40 ml per hour, and it can be very carefully monitored for signs of pulmonary edema or drop in saturation or tachypnea or increase in RR. Uh, the patient can be given injection NORAD, because NORAD doesn't increase the heart rate, or uh, patient can be given injection dopamine or dobutamine to increase the pumping capability of the heart. But we have to be very careful not to have tachycardias or tachyarrhythmias, because dopamine markedly increases the contractility of the heart, but they also can increase the risk of arrhythmia, especially SVT and VT. So we have to be very careful with that. And patient can be given injection vasopressin also, if the blood pressure has to be maintained. The best thing for MI patient with hypotension is the pump. We can always use the IABP, that is intra-aortic balloon pump, which actually uh, take care takes care of the coronary circulation as well. it improves the contractility of the heart also, and it reduces the risk of hypotension related complications. But availability of intra-aortic balloon pump therapy is a huge problem, and it is very available in very few centers, and it needs actually presence of cardiologist or a CVTS surgeon association or a great intensivist access. Then only this intra-aortic balloon pump therapy can be utilized. If the patient is hypertension, we have injection NTG, which can be given. The injection nitroglycerin can be given, sorbitrate can be given, or if if it is not responding to these medicines, then injection maybe labetalol can be also given to control the blood pressure. So depending on the blood pressure, we can use NTG or NORAD or adrenaline or dopamine, depending on the scenario whether the patient has hypotension or hypertension. The next thing is saturation of the oxygen. If it is normal, then there is no worry. But if the patient has hypoxemia, then definitely there can be increase in heart rate, increase in respiratory rate. Increase in the respiratory rate will increase the work of breathing. So patient will have to breathe more and breathe deeply. So which will automatically increase the pressure on the lungs. So automatically it will increase the pressure on the heart. So as already heart is suffering from heart attack, means the pumping capability of the heart is poor, or that if the saturation is less, because of the low saturation, the heart and lung will have to function more. So it will increase the workload on the heart, and it may increase the risk of hypotension or hypertension, or it may increase the risk of tachyarrhythmias, or it can increase the risk of heart failure, which we don't want. So in that scenario, if the patient has hypoxemia and if the patient has tachypnea, means if the patient's RR is more, we can simply put the patient on non-invasive ventilator to reduce the lung breathing, to reduce the respiratory efforts, so that the respiratory effort is reduced. So automatically the effort of the heart is also reduced. If the patient is very unstable, or if the patient has altered mental status, or if the patient is suppose if the patient gets cardiac arrest, then definitely we don't have any option than to do an invasive ventilation. And the fourth important, most important vital is respiratory rate. Tachypnea is very bad. So if the patient has tachypnea in any patient with myocardial infarction, the possibility could be the patient may have pulmonary edema, or the patient may have acute LVF. So in that, usually there is accumulation of so much fluid into the lungs, which causes this pulmonary edema or acute LVF, or accumulation of the fluid in the lungs, which in short causes activation of J receptors in the lungs, and which causes tachypnea. So for this, the best thing is we can give diuretics to flush out all this accumulated fluid. We can give diuretics like injection Lasix, by infusion pump, by at like at 10 milligram per hour or 20 milligram per hour or 30 milligram per hour, depending on the response to the diuretic. Or if the patient has this tachypnea and hypertension, we can use injection NTG, because NTG nitroglycerin is a vasodilator, so it will automatically reduce the left ventricular end diastolic pressure. It will reduce the afterload as well as preload, so it will automatically reduce the pressures in the lungs, and it may relieve the shortness of breath. NIV, as I told earlier, because of the left ventricular failure, because of the MI, there is significant accumulation of the water or fluid in the lungs, which may manifest as pulmonary edema or acute LVF. In that scenario, there is increased respiratory effort to increase to reduce this increased respiratory effort, or increased work of breathing, what we call it as work of breathing. We can directly put this patient on non-invasive ventilation or invasive ventilation. If the patient is comfortable on non-invasive ventilator, then it can directly reduce the work of breathing, and it can reduce the it will actually help for removal of all this fluid from the lungs, into the circulation, and that fluid then goes through the urine, and it responds better to the diuretics. How it acts, it's very simple. If just suppose this is all lung, it is just like a normal sponge which is dry. This is a dry sponge, which means this is a lung, a dry lung. Because of the LVF, so this is the heart which is not pumping because of the myocardial infarction. So there is all congestion in the lungs. This all fluid will get accumulated in the lungs. So this will not be like a dry sponge, but it will be like a wet sponge. So this wet sponge, if you want to reduce the functioning of, if you want to reduce the pressure over this wet sponge, you have to squeeze it. You have to squeeze it so that all the fluid get out of this lung. So how is that possible? The patient can increase his respiratory rate to do that, or you can simply put the patient on NIV. NIV does what is, it pushes the air forcefully into the lungs. So pushing air into the lungs forcefully simply acts like pressing or squeezing the lungs. And this lung, which is completely or significantly filled with water, because of the NIV, this small water, it is drained through the lymphatics of the lungs. And this all fluid which is drained into the lymphatics, after all, drains into the venules. These venules drain into veins, and these veins then drain into systemic circulation. And in this systemic circulation, this fluid can be drained out by the diuretics. This is how diuretics and NIV go hand in hand and work better if they are utilized in acute LVF or pulmonary edema or any MI. Very commonly, the patients do have anxiety. In such scenario, if the patient is very conscious, aware, obeying, then alprazolam or itizolam or injection fentanyl can be also given to reduce the pain and to reduce the anxiety. And if the patient is very unstable, or if the patient gets cardiac arrest or ventricular tachycardia, ventricular fibrillation, or asystole, then we don't have any choice then to give the invasive ventilation. So the next part we will discuss in next part. Thank you.